average costs for a family of four now are in the $30,000 to $35,000 range. Now, if the average wait time in an ER is 3 hours plus, the numbers just don't work. Where just not enough doctors to take care of people, particularly in the specialties.
AI or artificial intelligence, this could possibly be a way to fix some of the access issues. Well, welcome to another episode of the Leadership Lab, and today I'm honored to have a very distinguished guest here named Scott Becker. So Scott is the founder and publisher of Becker's Healthcare. It's one of the most influential media platforms in healthcare and a longtime partner at McGuireWoods. A Harvard Law graduate, author, investor, speaker, and podcast host, Scott has spent decades at the intersection of healthcare, law, media, and business building. His new book, Building Great Businesses, which I think he just has launched today on the 23rd of June, captures lessons from a career of wins, losses, discipline, focus, and scaling with purpose. Scott, number one, thank you and welcome to the show. I can't say how honored I am to have you here.
Well, Asbel, the honor is mine. I'm thrilled to be with you today, and thank you so much for hosting me, and thank you for the kind words. We can't wait to dig in with you today, so thank you for having me.
Absolutely. Well, a lot of our audience that'll be listening today probably know about or who you are. I've read many of the articles that you have kept us informed about, especially with what you've been doing over the last few years. So tell us just a little bit quick about what got you into healthcare, why you're here, and then I want to tell, I'm a story guy, Scott, so I've got a story that you aren't even going to know because this is the first time I'm meeting you, but I'm going to tell you how I intersected with you back in 2009, actually in the city of Chicago.
Well, fantastic. I'm looking forward to that. So that's not fair because I'm ready to hear that right away. So yes, I started Becker's Healthcare 30 plus years ago, and we really started in a niche, and we really started, people have these great origin stories where they say, I started a healthcare company because my mother's third cousin died of this or died of that. And that unfortunately is not, or fortunately is not the reality here. The real origin story here is I started this when I was a young lawyer trying to build a legal practice, build a reputation in healthcare and know the healthcare business, know the healthcare law and so forth. So I started publishing and writing newsletters around healthcare in a specific area in healthcare at that time before we expanded into hospitals and health systems in other areas. But it was really driven around sort of making my life and business around healthcare, both first in the law and then in the media business. It ended up being sort of it turned into a complete labor of love. But to say that it was because of some inherent interest in healthcare, which quite frankly, I've cultivated a huge interest in healthcare, but the starting point of it was quite different. I was trying to do what you think of as thought leadership today in the business I was in. And then at some point, what we were doing in healthcare publishing and events did become just so compelling to me that we doubled, tripled down on that, started to hire and grow a full team and really engaged fully in the health system world. And that's become my complete professional life, being involved in healthcare and following healthcare and trying to, engage with people and leaders and everybody in healthcare. And the beauty of healthcare is, one of the great beauties of healthcare is every single one of us is a consumer. So anybody can talk at you about what healthcare is and what the problems are. But the reality is we all see them every day because every single one of us consumes healthcare and we understand the challenges, the bottlenecks, the cost, the different things that are going on. And it's and it's one of the beauties of it. There's 350 million people in our country, and every single one of us, one way or another, touches or has to touch the healthcare system or get healthcare. And so we all have a very good lens on it, different lenses, but we all have a perspective on it. And so when somebody tells you from the health system world, from the payer world, you should be doing this, you should be doing that, they're talking at us, but we all understand it in a very real way because every single one of us is a consumer. And it's one of the things I love about healthcare and I love about talking about healthcare is everybody's got some pretty shared experiences, uh, you know, different but shared, regardless of how wealthy or poor, what race, what gender, what ethnic group, different but share experiences in different ways. So looking forward to visiting with you about it, Asbel.
You know what? You bring up that we're all a consumer. And I remember on my podcast a few weeks ago, I had Dr. Cozy, who's the chief medical officer for Chicago Fire, in your neck of the woods. And he actually said, healthcare is a business. And when you talk about a consumer, healthcare is a business. And I think once you start putting on that lens of it, how we come at healthcare, what we talk about, is going to kind of inform our conversation, because whether we like it or not, indifferently through that process it is. Which brings me to how I met you for the first time, and that was in 2009. And you had convened a panel, Scott, and you had brought in some of the big banks, and you brought in their CEOs at the time, and you actually brought in, it was like 4 or 5 of the largest banking or the financial institutions, and you coupled them with a panel with the largest healthcare systems to talk about what the banking system experienced under Dodd-Frank, because they would not work together to solve their issues, and the government had to come in. And generally, when government comes in, because you cannot put together some path to maybe fix your system or what have you, generally you do not like the outcomes of it. And they were talking about and giving their lessons learned so the healthcare industry would not repeat the same lessons. And I'm afraid that we are. And that is what's causing some of these significant legislative things that are beginning to happen, that has the healthcare industry kind of up in arms. And then introduced technology and artificial intelligence is bringing some things through. So I want to kind of pivot pretty quickly, and then we're going to end at the end of our podcast, because I want to hear a little bit about your book. I know you're not a first-time author, but I really want to talk about that book and what made you write the book from your experiences, because I can't wait to get my hands on it. We purchased several copies. I'm waiting for your personal autographs, but we're going to give some of those away as well. But really excited about that, and want to pivot very quickly, because I know you're limited on time, and so want to kind of first talk through some of the structural challenges of healthcare and cost. Everybody's talking about that. The economists are talking about that. Doesn't take a rocket scientist to look at that. You don't even need to have an acumen in healthcare to understand the trajectory that we are as a nation relative to the cost that the Medicare Trust Fund is going to expend itself if we do not do something differently. This administration is trying to do some things around fraud, waste, and abuse to possibly help it. Regardless, every administration from Obama to Trump to Biden to the Bushes, all have been relative to this, and you've interviewed many of these individuals. Tell me from your perspective. I know it's kind of in real time, and in my opinion, artificial intelligence has really moved this fast, because now we have access to data like we've never had before. So talk to me about what you're doing, the work that you're doing. Maybe those that aren't following you, I religiously read your review every morning. That's part of my reading piece of it, just kind of getting myself. But talk to us a little bit about where you are on that.
Sure. So you've got so many different points that are part of the American healthcare system, and we're at a spot where there's 350 million people, a million 100,000 doctors at most, about 4 million nurses. There's multiple pieces of this. We've got a daunting supply and demand problem. We could talk about structure and we could talk about payment systems as much as we want, but we've got an increasingly daunting supply and demand problem where just not enough doctors to take care of people, particularly in the specialties. On the primary care side, we've already sort of lost that war, but we'll solve it in a different way. But in terms of deep specialties, subspecialties, and this goes back to this concept that we're all consumers. Every single one of us knows somebody at a certain age that has died of a cancer, had a difficult cancer, a difficult prognosis, diagnosis. And it's harder and harder, whether you're rich or poor, you're connected or not, to find the right specialist to take care of the right person at the right time, just because we've got these daunting supply challenges when it comes to healthcare. Now, the positive side of healthcare is, of the largest countries in the world, and we have 350 million people, and people can't forget that we do a far better job than the other largest countries in the world in providing as much healthcare as we can to as many people as we can. Imperfect, lots of challenges. We get a B in it, a B plus, a B minus, but compared to some of the other largest countries in the world, we are in just a billion times better shape. But we're going to lose that if we don't take care of the supply and demand problem by figuring out a way. We've done a great job of accelerating the production of nurses the last couple of years, but we've slowed down, if anything, on the production of doctors, and doctors are being produced or matriculated at basically the same pace that they're retiring, and that's a disaster for a growing, increasing size country. The other thing I'll point to, Asbel, and is the triple aim. We've always talked about the triple aim as cost, quality, and access, and we're at a very precarious point in time, and this goes to the negative side or the pessimistic side, we're on the cost, quality, and access, we're going in the wrong direction, quite frankly, in all three of those things. Cost, talk about an immovable barrier, demographics is destiny, whatever you want to call it. Average cost for a family of four now are in the $30,000 to $35,000 range. That's the average cost for a family of four for healthcare. That's between co-payments out of pocket and insurance, but literally in the 30 to 37,000 range. The median income in our country, that's half the people make less than this, half make more, is about 84 to 85,000. So we've got this incredibly difficult situation where those numbers on cost just don't work. If you look at 84 to 85,000 of income, and that's half the people make less than that, and 30 to 35,000 in cost, the numbers just don't work. We know that healthcare inflation is caused by a number of different things. It's caused by not enough supply of the right people to take care of the right things. It's caused by workflow design. It's also caused by massive government dollars flowing into healthcare. Just like education in our country got way, way too expensive through massive government dollars flowing into it, we've done the same thing with healthcare. Now, the challenge is it's very hard to unwind that at this point. Because if you look at those numbers of the 37,000 and the 85,000, we just can't get health care to to the people that make less than 85,000 without huge government subsidies. So we've put ourselves in a spot. We've got this vicious cycle. We know that the government injecting trillions into it causes inflation. I think the cost of healthcare in our country this past year was $5 trillion. The cost of Medicare Advantage was $500 billion. I mean, these are big, big numbers, and you can't solve them by taking away Elon Musk's net worth. You can't solve them in all these ways that people talk about. You've got to figure out a way to solve them through supply and demand, a lot of it through workflow redesign, and we're seeing some real positives there. But you're going to have these subsidies for a very long time unless we could really get the cost down. So that's the cost side, because there's no way around. People can't get healthcare without us getting them subsidies if the cost versus the incomes are what they are. Quality, again, quality at the end of the day becomes a little bit of related to access. If we're increasingly in a situation where access is really tough, we all know you can't get a primary care doctor in many places without paying a concierge fee, which is a debacle for access. You and I are old enough to remember just 10 years ago when emergency departments would advertise, "We'll get you in 30 minutes."
Mhm.
Now the average wait time in an ER is 3 hours plus, and that's not because the public is doing something wrong. That's because people can't find access, so they end up at the ERs, whether they should be or not. That's where people end up at. Access is increasingly challenging. If you're rich, you're a little bit better off because you could pay concierge, you could call your hospital CEO, you could find some access. But even for people that are wealthy and affluent, it's getting harder and harder because there's only so many times you could call hospital leadership without them saying, "Leave me alone," no
Yeah.
matter who you are or what you do, unless maybe you're the president or you're in Congress. The rest of us, it's challenging. And that's for those that are connected and affluent. For those that are not connected and not affluent, trying to find the right provider at the right time, trying to have access, increasingly challenging.
Let
A-
me
And, then,
ask you. Let me ask you this, because you talked about subsidized care, and we've talked through that on the access issue. Of course, my background in the industry started in the emergency ambulance space, Scott, and that was what you're talking about, access. Where there is no access, they revert to calling 911, or we go through that portion of it. Let's talk about the unsubsidized area. As a business owner myself, for instance, last week I got what our increase was going to be for the health care that we provide to our employees. It didn't just go up 30%, it went up 77% is what they came back with. That is literally I literally was floored when I saw it and said, well, we've got to do something different and we've got to figure this out. And so I've got lots of other people working on that. But I had one of my CEO friends tell me, Asbel, be prepared. It's going to go up 30 to 40%. Ours went up 42%. Mine, I got 77%. how is that factoring into? I get the subsidized argument, but this is kind of an unsubsidized argument where employers might have to start making a difference. And I know Mark Cuban's been focused on this, on some of the intermediaries that employers need to get more engaged. But I'm not a large employer like he is. So I have limitations. How is that
And so
factoring
what
in?
happens is you're actually in the exactly almost the worst spot in healthcare in terms of cost because you're not quite impoverished enough to be subsidized. That's not an argument to be subsidized. You're not big enough to have bargaining power with the payers. You're sort of in this small insurer marketplace, which is the worst place to be because insurers don't want to cover it. They don't want to deal with it. They want to deal with big employers, not small employers. They have to deal with it. And thus, what happens is because they have to deal with it and they don't want to, they end up, you get charged a lot of money because you're sort of, they have to do it as part of the system, but don't really want to do it. And so you're sort of in this, it's exactly what Obamacare was in part intended to fix was access for individuals and small businesses and so forth, but ultimately, in many ways, did some great things, but failed to address this issue. But yeah, and I don't know a great answer to that. You've
Sure.
got a situation where the real answer is going to be
Yeah.
healthcare going back to really being for catastrophic coverage and people really paying for a lot of their healthcare out of pocket and only getting to where, it's almost like a car accident. You really have car insurance when something really bad happens, you don't have it to fix the $1,000 fender. You've got it for like when there's a real problem. And what you're going to move towards is more and more, all of us paying for our own physicals, our own everything. And then you're going to drive down the cost of some of that too. You're going to drive down the cost for 80% of the care that's not emergent, that's not catastrophic, and you're starting to see some headway in those areas. But it's gonna take time, but the only answer really is the movement towards lower priced ways of doing business and keeping the higher priced stuff for the really important stuff, whether it's oncology, cardiology, the things that are the most important things or the most chronic diseases.
And so that kind of leads me into the next question around the patient. There was a effort by Congress with the No Surprises Act to kind of move out some of this piece that was this was something that happened at the last minute, but it's around the emergency care if a patient gets treated, whether it's in network, out of network. There's a lot of varying opinions from the payer community, the provider community, but ultimately the patient has been in the middle of that. This kind of removes it and lets there be some type of process. Do you believe from what you're seeing or whatever that this has started to assist? I know that there's some data out there. Of course, there's still this argument between payers and providers around the no that it needs to be opened back up, looked at again, or what have you. Where are you at on that and keeping that patient out of the middle?
Yes. Yes. So the No Surprises Act, I mean, let me we'll talk about the No Surprises Act specifically.
Yeah,
The No Surprises Act, and again, people have different opinions on this.
sure.
This is phrased as something intended to protect consumers from essentially out of network billing or surprise billing. When you show up at a healthcare provider, you have no control of it at all, that you can't be surprised with too big a bill or an unexpected bill. What really the driver behind the No Surprises Act, the No Surprises Act was not it on its face, it might be sound like it's intended to protect consumers from getting charges they didn't expect. Like you get a surprise bill from the anesthesiologist, you get a surprise bill from the emergency department. You show up, you have no control, you have to show up, and you get a bill that you just can't handle. The real driver behind the No Surprises Act has nothing to do with individual patients, has nothing to do with individual pocketbooks. It was entirely driven or largely driven by the insurance companies that themselves wanted a ceiling on what the bills were from out of network providers. So this led to this arbitration process, mediation arbitration process that became part of the No Surprises Act, where it drove hospitals to try and be entirely in network for all their providers in the hospital. But it still left a lot of these arbitratable disputes. What's happened with the No Surprises Act, it's not driven down individual healthcare bankruptcies at all. It's had no impact on it at all. What it led to was the insurance companies trying to set a ceiling on charges they would get from providers that billed out of network. It's turned out the insurers have done quite poorly in the arbitration process in that effort. So they're trying to change that again now. They had really pushed for the No Surprises Act but it's not turned out as they wanted it to, and it's had no real, as far as I can tell, it's had very little benefit on the U.S. healthcare economy. I mean, it's sort of just one of these things that was really pushed by the insurance companies under this sort of like mantra of apple pie and protecting consumers, but had nothing to do with protecting consumers. It had to do with protecting insurance
And
companies.
that is tamping down the cost. It hasn't had really no impact on decreasing what they thought or what they alluded was the problem, but because providers were egregiously charging rates to subsidize, and that it would cause major premium dollar increases. I don't think we're seeing that currently in the
At all.
data. It's
And certainly
anecdotal.
there are some providers, whether you're
Sure,
in fee for service or capitated care,
sure,
there is some percentage of payers or providers that will abuse the system. I mean,
sure.
there'll be
Absolutely.
5% on the fee for service side. There'll be 5%. The insurers all got rich during COVID, not for good reason, but because they weren't providing services, because surgeries weren't getting done.
Right.
That's not better health care. That's just rationing care or reducing care.
Looking at budget cuts? Running out of cash? Look no further than the third payer. You already know the two payers on every claim, the patient and the insurer. But in accident cases, there's a third payer you never billed, and they've been off the hook this whole time. Black Inc.'s TPL Discovery surfaces the third-party liability, so the right payer finally pays. On average, we hit on greater than 50% of the accounts we run. Revenue you already earned, recovered. We'll prove it first. One complimentary run, no cost. There's a third payer. Let us help find them. DiscoverBlackInc.com.
So here's kind of where I want to move to. I want to kind of pivot a little bit as we kind of work through our outline, is the administrative burden that is in the system and the program. I had a doctor who was a former president of Blue Cross Blue Shield of Texas on my podcast. We actually just released it yesterday. And he kind of talked through that, hey, payers don't like all of the burden associated with pre-auths or anything no bigger than what providers do. And there's a gamesmanship that happens. One has different incentives through the process. But how is the administrative burden in the healthcare system? Is there some things that we can do? I know there's a lot of discussion happening at the federal level on can they do some different things around, can we use AI? Can we do some things like that? But how much of that is contributing to what we're seeing going on right now?
Well, it's certainly a piece of it. I mean, we've ended up there's three or four things that have really driven cost. I mean, you've got administrative costs. Think about a $5 trillion system. Medical loss ratios, when they were low for payers, were down at 80%. Now they're back up to 88 to 90%. But think about that for a second. If medical loss ratios are at 85 to 88% in a $5 trillion system, that means we're still spending on administrative costs $500 billion to $1 trillion on just administrative cost out of our entire economy of 26 trillion or so, or 27 trillion. If you look at Medicare Advantage and administrative cost, the whole idea with Medicare Advantage, much like the No Surprises Act, much like all these things, that is supposed to reduce the cost of care. At the end of the day, Medicare Advantage is costing on average more than is traditional Medicare on a per capita basis. So it's been just an unmitigated disaster in a lot of ways. And on top of it, providers and patients don't seem to like it very much. Unless you're the small cadre of patients in their early 70s that's taking advantage of some of the extra services you might get in Medicare Advantage. The rest of the population seems to be doing poorly with it. But you look at the administrative cost, it's literally out of control. I mean, you've got 50 different payment systems with Medicaid. You've got Medicare. You've got the VA. You've got 7 big, huge payers. 4 of the payers are amongst the 20 largest companies in America. So when you get past Amazon and Walmart, you get right to United and CVS, and then Cigna and Elevance are also 4 of the largest 20 companies in America by revenues. Those are astounding numbers that we've got flowing through the system. What's happened in terms of the flowing through the system and the cost of the system, we've got 50% of healthcare is now governmental between Medicare or Medicaid or around that. And that's all, that is what it is, and it's fine. In terms of pre-authorizations and so forth, you've got this arms race that started between payers doing exactly what, a lot of government healthcare. Medicare Advantage, more than half of Medicare is now Medicare Advantage. A ton of the Medicaid programs turn their programs over to managed care providers, Centene, Humana, and others. This is not a knock on any of those companies. Those companies are doing exactly what DC has asked them to do. They were intended to be in a spot to be a middle person to try and control cost. So states did the concept of we've got this amount of budget, we'll turn it over to this company. They'll be in charge of managing within that budget. And the reality is, you either have care improvement and care redesign, or you have no, the word no, saying no. And the reality is, care design and care improvement is really hard. It's really hard changing work. Saying no is much easier work. So when managed care payers got medical loss ratios down to 80%, it was really through different ways of procedures not getting done. And so when I see, and Asbel, I don't mean to drone on this, but when you have Congress yelling at the payers about pre-auth and denials and so forth, and the Congress people being up in arms at the payers, to me, this is the greatest stage for hypocrisy because Congress turned over the money to the payers to do exactly this. To essentially, somebody has to say no or figure out how we reduce the cost of care. Actually changing delivery models is really hard work. So you end up with, instead of people really changing delivery models, you're starting to see the change of delivery models by necessity. But a lot of reducing cost came down to pre-authorizations and saying no. And this causes, on the provider side, tremendous burnout because you're in a losing arms technology race where the payers for the largest companies in America are just way ahead of the systems and the practices. So they say no. Then the providers, the health systems, the doctors have to have tools to get them to say yes. And you've ended up in a situation where it leads to a vicious cycle of spending tremendous amount of money on the administrative side of healthcare versus actually getting money to doctors, nurses, and the care that our patients need. So I don't know if I've just dumped
No,
on you, but let me
no, I
stop for a
think
second.
I let you kind of talk because I think that needs to be said. You are actually saying out loud what a lot of people are talking about behind closed doors, or we know this is emblematic of the problem. And so you're actually saying what needs to be said. I mean, there was an article that came out this morning that I was reading that 23 Medicare Advantage programs have pulled out. And they're citing just because of issues relative to there's not margins there to actually continue to keep providing the care that they generally do. And I remember I was talking to a healthcare economist that actually did their thesis to get their doctorate in the Medicare Advantage program. Dr. Miller, who's a MedPAC commissioner, an internist at Johns Hopkins, talked about the same thing, Scott, relative to what the data said, that the majority of individuals that switch from Part B to Part C are either minorities or underinsured individuals. Generally, the upper middle class and wealthy are generally going to have Medicare Part B. Because it just becomes about healthcare economics at that point in time. And so the more people that pull out, are we going to start to have more of an underinsured issue that we had 2009, 2000, before the Affordable Care Act came in to try to work through some of those things? That's what I'm a little concerned as we start seeing these numbers. What does that look like?
A huge issue, and you point to the Affordable Care Act, and it's so important to discuss because the great benefit of the Affordable Care Act is it took down our uninsured from about 20% to 10%. And having people covered versus not covered is something that every single one of us should want. We should want coverage for all. Now, coverage for all is a really good goal, but it's also only half the goal because coverage for all without fixing supply and fixing access is akin to writing a check you can't cash. So when the politicians talk about, on one hand, you have the politicians on the left talk about Medicare for all and coverage for all, and just to be as clear as day, I want there to be coverage for all. I think we all should have coverage for all. I think, quite frankly, most health system executives, most physicians, most nurses want there to be coverage for all. But if you push coverage for all, but don't also push for fixing the supply problem, you've put together an illusory solution, a fake solution, because you don't. If you can't get to a doctor, can't get to a nurse. I remember last year I had to reschedule my primary care visit. It was scheduled for April or so, and I needed to get something later in the year. They told me the next available appointment for my primary care physician was next June. Was literally 14 months out. And again, and I'm relatively affluent, live in a nice area, whatever, all those kinds of things. Imagine how bad that access is for a lot. I mean, for me, it was a 12, 14-month wait. Imagine for those that are in that part of the population that are considered Medicaid or impoverished or what have you, or make less than the median income. It's just a brutal situation. So solving coverage, great. But solving coverage without solving supply and access is just political grandstanding. On the right, just as bad. The right talks about, one of the great signs in the last political campaigns was get the government out of my Medicare. And this, of course, is ass backwards, of course, because of course Medicare is government. That is a government program. Medicaid is a government program. So when you hear people on the right say just let free market solve it, that's not going to work either. It's going to be some mix of free market and government if you're going to fix healthcare. And there are some great free market and other solutions evolving, but they're going to be coupled with government because government pays for half our healthcare in our country at least,
So
or
let's
close to
talk
it.
about access, because that's where a key component that I just keep hearing a resonating theme through our discussion right now is access. And couple that, and I want to kind of move us into this AI or artificial intelligence conversation, because everybody's talking about that this could possibly be a way to fix some of the access issues. This morning, I'm a story guy. I like to tell stories. This morning, I was talking to a company that's very innovative in this space. Of course, the Rural Health Transformation Program is really making people think through this construct. It looks like CMS, and they're going to hold the state's feet to the fire, making sure that their programs are innovative. There's a lot of discussion about that. There's an article from the state of Maine regarding this, how they had to do some redesigns. I think it even came out in your your news stuff. But let's talk through that from that piece of it, because there's some very innovative stuff that's beginning to happen. But innovation for the sake of innovation without the results to go with it is kind of where I'm at. I'm a technology company, so I'm all about the innovation. I love what's happening here. Is there a way to solve some of our access issues by looking at the way that we do delivery differently? I get your point about saying no. That's the easiest way to get it. But let's talk a little bit about that, Scott, from your perspective of, can the intersection of AI with care delivery produce some issues with access? Maybe physicians don't have to treat as many people, and so that helps with workforce shortage?
A huge amount of potential positives. Yes, absolutely. I mean, where you see sort of big positives already is you see sort of technology coupled with licensed providers that we have an easier time producing in our country. I'll give you two different examples of where technology is making a huge difference. And but for the technology, we would just be overwhelmed. And I'll give you two different examples. One is primary care is a fascinating situation in our country. There's about 450 to 500,000 primary care physicians in our country compared to 350 million people. So this means the old model of primary care where you or I had our own primary care physician, and we love that person. We've had that relationship with that person for 30 years. That's largely broken for most of us because when my primary care physician retires, I'm either getting the fractional care from different places that a lot of people are getting, or I'm paying a concierge if I could even get one at a reasonable price. Because assuming I can't find just a replacement primary care in the traditional model. But what's happened on primary care, and I often say the era of physician-driven primary care is coming to an end, and it's a very unpopular sentiment amongst there's an association of primary care physicians, and I love them. They do great work. But we're producing, just to give you numbers, we're producing 200,000 nurses a year in our country again, greatly up over the last few years. We're still only starting 23,000 doctors a year. So by sheer necessity, a huge amount of care is going to go to urgent care, nurse practitioners, PAs, other providers at both a lower cost and a relatively high level of ability when coupled with technology. And there's almost no way around it. It's almost by necessity. When people in Washington say we need more primary care physicians, I will say their substitutes are not as perfect, they're not as good, but they're pretty good, and they're getting better and better between nurse practitioners and CRNAs and PAs coupled with artificial intelligence, and there's no way around it. There's no way to turn back because it takes us in our country 4 years of medical school, 4 years of college, 3 to 4 years of residency to produce a doctor, And so the pace at which we produce doctors, we're producing about 10,000 primary care doctors a year, and about 10,000 primary care doctors a year are retiring. And you couple that with the fact that in terms of a huge percentage of doctors going part-time by 40, 45, 50. And this is all daunting, but it leads to the fact that primary care as we know it is being replaced by a combination of artificial intelligence, technology, together with NPs and PAs, and it's pretty good. It's not perfect, but it's pretty good and gonna get better. And the sheer numbers, if people use the phrase demographics is destiny, just like we have an older aging country is going to have more people to take care of. It's the same thing here. If we're producing 200,000 nurses a year and only 23,000 doctors are starting medical school a year, more and more of our care is going to be provided by licensed providers below the level of a physician. There's just no way around it, coupled with technology. So that's one a great example where this is moving dramatically with the help of artificial intelligence. We said earlier, Asbel, that all of us are consumers. When I was sick over Christmas break, I of course went on ChatGPT to see what was wrong with me. It was 98% right. I then went to the urgent care. The urgent care nurse practitioner took care of me, or PA took care of me in a wonderful way. It was essentially the same diagnosis I'd given myself, and I don't want that to be the final diagnosis. I want that human in the loop. That person prescribed something. I was better in a few days. Fantastic experience. And these are just anecdotal looks at where things are going, and you're gonna see that happen. And what you'll see over time is more and more of our allocation of easier things being done by artificial intelligence and nurse practitioners and PAs and primary care physicians, which should allow us, if we're smart, to allocate more resources to training specialists and harder to take care of things with subspecialists and specialists and so forth. So that's one part of the equation where technology is having a huge impact, not maybe a 10x change, but certainly a 2x change. The other place that I see that I think is fascinating, and I won't talk about the medicine, the GLP-1s, the medicine, but what I will talk about is the method in which they're being prescribed. If you went back 3 years ago, anybody that was getting a GLP-1 went to their doctor, went to the health system, and got it. And then you had a ramp of GLP-1s. I don't know what the number is today, but it's tens of millions of people that are somehow or another dealing with GLP-1s. And if those people were still going through the traditional health system to get them, the traditional health system would be just utterly swamped. But those people are going through telehealth providers aided by technology and AI to get their prescriptions done in a billion times more efficient way, in a way that seems to be working really well. It's not that there won't be some hiccups with it and some problems with it, but at the end of the day, that is taking a huge amount of stress off of the health systems where people would otherwise be getting all those medicines. Literally 20, 30 million people would be getting them through the primary care doctor who's already overwhelmed, the primary care doctor's office is already overwhelmed, or their health system. And that's just a movement that's enabled by technology and AI in different ways of doing things. And I think you'll continue to see these evolutions almost, this is the beauty of this mix of government and private enterprise fixing things is we start to see solutions. And it's much like many things by necessity, but things that I wouldn't have expected. I mean, you wake up one day and it's a who moved my cheese
Yeah.
moment. All of a sudden, 20 million people a year are getting their care outside of the traditional health system for a new type of drug. And on top of it, the pricing has gone down for it because it's no longer all flowing through insurance companies and subsidies.
Which is amazing to me. And I think what I'm hearing from you, and I just had this with Dr. McCoy that talked about this, is AI has introduced that the patients can now take back control of their health care. This is, in my opinion, the most revolutionary moment of anything because many times there was not an optic into healthcare. You didn't have, like, things could not be, but now AI is providing that movement. Like you gave an example of using ChatGPT and you got yourself 98%. He gave an example of how he loaded all of his, like, he's created this whole AI. It's amazing what he's doing as a dermatologist, worked for Baylor, does a lot of stuff nationally. But Dr. McCoy talked about how he loaded his own personal stuff into, found out stuff as a dermatologist himself that he didn't realize, made the connecting point, was able to go to his primary care physician with information that was like, wow. And so it's almost like I'm taking control. So we're giving more back because patients will make different choices when I now believe that I can do, Ronald Reagan said it, trust but verify. And so literally you got to embrace it. And that's been the conversations in the last 90 days. I know you're having tons of them, but people are looking at the ambient AI side of it. Now we got to worry about notice and consent provisions. And, now the attorneys get involved. That's a whole other conversation I want to have is, do we need to have tort reform? Do we need to look at something differently as we move into these markets? Because generally that's what prohibits sometimes or inhibits, innovation and moving rapidly through a process. But to me, AI is probably the biggest move my cheese moment that the healthcare and payer industry is grappling with right now from the provider perspective and the payer perspective is the patient is now much more involved than they used to be, and they can validate almost everything they do right now. And so I kind of have a few more questions for you. I know we're getting in. I want to be cognizant of your time, Scott, but I know people are very interested in AI. It's the one thing that everybody wants to talk about right now, and I really want to talk about the positives of it. People are no longer saying don't use it anymore. They're embracing it and saying, how can we do it better? How can it augment what we do? How can we provide this stuff back to the patients? How is that patient involvement? That's the one thing I want to talk about because that's what I'm advising my clients who I talk to all the time. You need to embrace it and think about it through the eyes of the patient at this point.
No, I think that's exactly right, and I love your phrase, "Trust but verify." So we'll come back to that in a second. But I think in terms of AI, you're always looking for in every system, what's the limiting step? What's the stopgap? What's causing or stopping movement? And so one of the things that happened, and I'm sure it was part of Obamacare or a different law, but the law today is when your test results are ready, they go to you, and you don't have to wait for your doctor to send them to you. And we were all, of course, very concerned about this. There's still concerns with it. So you can get your test results, and they can be a bad test result, and you can't get access to your physician. But in the old days, people were waiting weeks and 10 days for their test results because their doctor didn't have time to call them to tell them, yeah, your thing came back benign or it became back, malignant. You didn't know. And so this is part of the first step in care moving back to the patient and so forth. And I think artificial intelligence is a huge part of that. In the old days, you had a stopgap, a limiting step. We've all seen it in all kinds of different businesses, but I can't get this done without going to see that doctor. But I need this, or I want this, I want to try it, and I can't do it without it. And one of the beauties of artificial intelligence, it opens up so many of those doors. I mean, just think about so many people on GLP-1s. If they had to make a doctor's appointment to do it and go see the doctor, you just couldn't do it. The system just couldn't handle it. It'd be overwhelmed. And you're going to see so much of this. Like when I get, this already happened a long time ago. If you went back 10, 15 years ago, it started to get harder and harder to get into your primary care office. So all these urgent cares opened up. People went to urgent care. And this is what you'll see with AI, this evolution towards AI, towards different ways of accessing care that hopefully will take stress off the system. It will be imperfect for a period of time, just like self-driving cars. At some point, we'll get to self-driving cars. I don't know when it will be, but it's almost inevitable because we know how much risk there is in all of us actually individually driving. Not good nor bad. I mean, and I recognize as much as anybody, there are millions of people that make their living driving cars. So it's very scary to see the transformation. But just like as we see, there's so many pieces of care they'll be taken care of with artificial intelligence. I love the phrase trust but verify because I'm a big believer we're going to keep on leaning heavily into artificial intelligence, but we better create enough nurses and doctors to take care of people just in case or side by side with it. So I'm a huge fan of the phrase trust but verify. Probably grew up in the same generation as you if I'm not a little bit older, but we talk about that phrase all the time.
Oh, yeah.
Prevention's great, but we better have enough nurses and doctors too.
It's the only way that we can make it through. In the last few minutes of this, I want to pivot to what I hear a lot, and I'm sure you hear a lot as well. Asbel, this all sounds great. We get it. We understand. We've talked about there's been some things been like, wow, how are we going to get this system fixed? But generally, it comes down to reimbursement. Catholic charities say it best, no margin, no mission. And so that's what makes our healthcare system here in the United States so well is we do have a lot of innovation. We're a free market society. Whether there's a debate one way or the other about should that be in healthcare or not. I'll let other people debate that piece of it. But we talk about private equity coming in. Venture capitalists has been wonderful. I've had some great pieces. There's been negatives to it, positives to it. But let's talk about the payment system, the reimbursement system. That generally seems to be where things start to go down fast, quickly, is we talk about all these innovative models. We talk about value-based. Obama, the Affordable Care Act, actually created an innovation center. We started trying to do ACOs, different things like that. And then ultimately where things break down, it's like, well, there's not a value. We're not making money. There's not what we thought it was. We're losing money on the same type of the care of the patient. If you had one or two things, Scott, that you could say, we need to really look at this in this type of model, what would that be?
Yeah, and I think whether it's fee for service, it's capitated payments, it's whatever system you have, it's I come back to core economics. A lot of this is supply and demand. So you could change the payment system all you want. I mean, it's James Carville famously said during one of the elections, "It's the economy, stupid." I would say, that it's supply and demand. So much of this is supply and demand. If we don't constantly work on the supply and demand equation, 350 million people, not nearly enough specialists, not nearly enough supply, we're going to have trouble. And constantly work on the technology and other ways to fill that demand. But I think you have to come back to like the best CEOs that I talk to spend so much of their time on something that you hearken to. Are we taking care of patients better or not? Are we getting better quality or not? I mean, everybody and their brother and sister has a different new payment concept they want to try. The history of payment evolution at Medicare, CMS, and government has been one disaster and mistake and miscalculation after another. Doesn't mean we shouldn't try them periodically and so forth. Remember, when they first introduced home health, the concept is this is going to save the government a ton of money because it's going to get people out of hospitals to home health. That ended up being, of course, a massive miscalculation. It meant that the healthcare provider system was able to hold on for patients in a different way and for longer and cost the government a huge amount of money. Same thing with hospice care. There's all this discussion about should we pay the family member who's helping to take care of their mother? Should we pay them as well? Anytime you open up new payment mechanisms, and somehow or other, there's an idea that that will save money. There's no way in the heck it will. It just is what it is. But I do think so much this comes down to I have been listening since back in the day, Uwe Reinhardt talk about the payment system and how we need to fix the payment system. And there's been so many different experiments with the payment system. I really come back to so much of this is supply and demand. And then if we fix supply and demand and we take care of people in different ways, keep on coming back to your core question, are we taking care of patients well? For example, can I be taken care of well for what I have, what ailment I have, by a nurse practitioner versus or a PA versus a physician? And is the cost of educating and training that NP or PA 4 years of school versus 12 years of school, then we should be better off. We should be in a better position. You follow me?
Yep.
But I think so much this is about care redesign, taking care of people, finding the best lowest cost denominator to take care of people. And we've got to fix medical education in our country. This is just totally. We produce great doctors, but we do so incredibly inefficiently, and that's part of the supply and demand question. But I don't mean to pivot from your question,
No, because I
but
think it's really important, Scott, what you're saying, because you mentioned the education to the medical physicians, and I had my first aha moment, and I've been in this for 29 years, when I was talking to a physician, Dr. Cozy, and many have actually talked about that. I didn't realize that they went through almost 13 years of school with no education in healthcare economics, with anything. It was amazing to me that the way that they learned was by a mentor, or they had to go back and get their MBA. And
right.
that was very enlightening to me, because I believe we have this is my personal opinion, and I believe if we go back and let the data and the doctors lead this discussion with the right leadership, where people sit and listen to each other and stop talking over each other, putting us into different silos, that we could fix this system by keeping the patient in the center. But that was an aha moment to me, that the physician community didn't understand the healthcare economics of delivering healthcare.
No, and I agree with that 100%. And the patient at the center of it is completely right. I'll go back to medical education. 4 years of college, 4 years of medical school, 3 to 4 years of residency, 1 to 2 years of fellowship. So, and often a gap year between college and medical school. So, doctors don't get out to 31, 32. Growing percentage of doctors go part time by 40. We've got a disastrous education system. We produce great doctors, and a lot of it's done by rote, by rotations, by other kinds of ways, which is all great. Other countries are doing this. They're cutting 3 to 4 years off of this. The kids are going right to medical school from high school in a lot of countries, and the proof is they're producing great doctors. Some of our best doctors in our country did medical school, were done by 23 in other countries, came here for residency at 23, 24, done and ready to practice, fully baked by 28, 29 versus 31, 32, 33. And it just is, but we've got a messed up system here where we can't seem to fix this. Even when you and I were younger, many colleges had 6-year med programs where you finished college and medical school in 6 years versus what is 8 years. The last year of medical school now is all rotations. So you're paying tuition, but you're rotating throughout the country at different places. I mean, it's really become a bastardized system. We produce great doctors, but our medical education was developed prior to the internet. I mean, it's literally insane. Nurses face the same problem. 3 to 4 years ago, they said, we can't educate enough nurses because we need to have enough mentoring and enough senior nurses to teach that. What happened over the last 4 to 5 years is we've moved back to producing 200,000 nurses a year. We retire about 160, 180,000 nurses a year. We're actually moving in the right direction on nurses, which 3 to 4 years ago people said could not happen. That it wasn't because there were sort of stop gaps in the system that stopped us from, or limiting steps. We have fixed that on the nurse side. It may be imperfect, but it's a huge move in the right direction. We have to do the same thing on the physician side. We're all going to be incredibly short physician specialists as we age and as our population grows.
Well, I could sit here and talk to you all day. I'm going to do a little lighthearted question for you, Scott. What keeps Scott up at night?
Yeah, what keeps me up at night is Liz is snoring. No, I'm kidding. I'm kidding. And if she hears this, she might shoot me. She might shoot me how much she snores. No,
We'll edit
no,
that out.
no, you don't even have to. No, what keeps me up at night is the constant battle in life to stay useful, to stay effective, to stay part of the game and be useful. I mean, that's really, to put it at the end of the day, what keeps me up at night. I mean, there are so many challenges around us, whether in the world, in healthcare, and other places. I try and remind myself, for a country of 350 million people, we do an incredible job of taking care of everybody. Imperfect, lots of challenges, but we do a lot of things right. But I'd say what keeps me up at night is Liz snoring, too much coffee, not enough exercise, all those kinds of things. And I know that's not what you mean, but yes. But
No, I
I
love
think
it. I love it. It's a little humor. It's a lot that you've been talking about today, Scott. And I will tell you, you've been a wealth. And the medical education I'm going to pursue, you've got some really good ideas that you just talked about here. That's very interesting to me, that I actually agree with and haven't really thought about that piece of. I got it clear. And anybody that's listening to this, supply and demand is the issue that we should be focused on as the core fundamentals. Everything else will start to fix itself. Tell us in the last minute or two about your new book that you just released, and how some of our audience can get a copy. We're going to be giving some of this away as well, so our marketing team is going to love it. But tell us a little bit about your book and what prompted you to write it.
Sure. So I wrote a new book. I'd written several books a long time ago on healthcare and in the healthcare world. Then more recently, the last 10 years, I'd written some books on business. This book is the third iteration of a book on business. The first one was awful. The second one was okay. We think this one is solid. It's called Building Great Businesses. It's sort of both a lot of business lessons that are interweaved with the story of building a business. Again, it's somewhat anecdotal because it's not like Jim Collins, where I've studied a million different businesses. It's more a little bit of a mix of personal experience, boards I've sat on, investments I've made. Some have gone very poorly, some have gone fine. But the businesses I've built too, between Becker's Healthcare and building a legal practice and a lot more, and the things that we've seen, and sort of our advice on building teams, on niches, on point solutions versus broader solutions, and a whole lot more. So it was a great project for me. We hope that people enjoy it, that resonates with people. It's available wherever you buy books. It's called Building Great Businesses, Create Momentum, Overcome Setbacks, and Scale with Confidence. Asbel, I am so thankful for giving me the chance to visit with you today. what a pleasure, and to take a moment on the book. But the real focus today is healthcare, not the book. But I appreciate it so much getting the chance to at least mention it. So
Well,
thank you.
Scott, thank you very much for that. Thank you for contributing in and putting stuff into us who are business leaders. I plan on reading the book. We purchased several of them, and you've been gracious enough to autograph them for us and a few that we're going to be giving away as well. But thank you so much for taking the time to come on the podcast and give us such a breadth of knowledge and your input into the current system here in healthcare and maybe how we can dig ourselves out of this and address the supply and demand issues.
Asbel, great privilege. Thank you so much for having me.
Thank you so much for being here. All righty.